Just
welcome.
can't get my camera to work, but I'm here.
Okay, we
So
will have to deal without being able to see your smiling face. But we
I'll
will be
see what I
okay.
can do between my phone and my iPad. So yes. Um, so you're asking for call to order?
Yes, please.
So I welcome you all to the September 19th meeting of the Health Evidence Review Commission Evidence-Based Guidelines Subcommittee, and I call us to order. Thank you.
All right, and can we do a roll call?
Yes, let's start with Larry. And we can't hear you, Larry.
Yes, I'm here.
Okay.
Yeah.
And who wants to go next?
I'll go. I'm Kat Livingston. I'm the medical director of Health Share and a practicing family physician.
Thank you.
And Mark Buckholtz, medical director for Pacific Source.
Right.
And Marian McDonald, I'm the Medicare medical director at Pacific Source and also for Medicaid in the Columbia Gorge region.
Thank you. Next.
This is Deb Espeseta.
Deb, you're breaking up a little bit for us.
Yes.
Yeah, I think I might need to change my Wi-Fi,
Okay.
but I shouldn't interrupt. I should still be here. But yes, this is Deb Espeseta, licensed acupuncturist.
Great. Is that it? All the members? I think so. All right. And approval of minutes?
Yes. So hopefully everybody's had a chance to read and review the minutes from our last meeting. If so, and if you want to move those forward, we need a motion to approve. Anybody want to offer that?
Make a motion to approve the minutes from the last meeting. This is Mimi
Thank you.
McDonald.
Yeah, thank you, Mimi. Who's next?
This is
Second.
Larry Lyon. I second.
Thank you. So we've had it moved and seconded. All in favor, please put your approval or not approval, your vote in the, we need to put them in the chat. I think that's what I remember. Is that correct?
Okay.
Yes, but just please make sure that you're not direct messaging me, but direct messaging everybody. Thank you.
Where is the everyone?
If you click on the
Oh,
two, you can
oh,
find
yeah.
host and
Okay.
panelists. Yes,
Yep.
there you go.
Yep. Okay. Thanks.
Okay. So Jason, I think that's the first item off the agenda. Is that correct?
Correct. And the next item is just something we've realized we need to be doing, give everyone an opportunity to declare any conflicts of interest with the topic at hand today, which is the hypoglossal nerve stimulators.
I'll go first. This is Larry Lyon. I forgot to introduce myself. I'm a family doctor here in Eugene, and currently a volunteer at the VMO Clinic in Springfield. And then regarding the current topic, I have no conflicts.
Thank you, Larry, and sorry we missed you a moment ago. Daphne is out today, so we are scrambling a little bit. Hearing no other conflict of interest, I think we can go ahead with the staff report. Liz, I sent you the benefit update slides.
I have that.
Yep.
Do you not want to do
Perfect.
the orientation slides?
Oh, let's do the orientation slides first. Thank
Okay.
you.
Okay, yeah.
Go ahead. So just to remind everybody of our purpose here today and what we're doing, OHA has a goal to eliminate health inequities by 2030. Of course, that's an aspirational goal we're working towards. Our purpose today here at this meeting is to develop reports to guide coverage for the Oregon Health Plan and other plans in Oregon. At minimum, these decisions will affect the over 1 million members of the Oregon Health Plan. as well as families, caregivers, and providers. There won't be any decisions about individual care today. Go ahead. So the Evidence-Based Guidelines Subcommittee, or EBGS, develops coverage guidances and multi-sector interventions reports to guide the coverage of health services, again, by all health plans, including the Oregon Health Plan. Reports are not final until approved by HRC. They will be implemented at later dates. So there's a process for any decision made today. This is not the last step. Major considerations include what outcomes are important to patients, the subcommittee's assessment of the harms and benefits balance, patient values and preferences, stewardship of public resources, and the nature of the healthcare delivery system. Members, please generally be on camera and attentive. If you need to step away, since Daphne's not here, if you could just put something in the chat or message Jessica so we can keep track of quorum. Again, Jessica or me for logistical issues, and we'll ask you to vote in the chat today since everyone's online. And I don't believe we have anybody offering verbal testimony today, so we can skip that part. Other questions for those of you attending from the public, you can use the question and answer feature to ask questions. Don't ask Daphne because she's not here. Please ask, why don't you ask me for today? And anything put in the chat or Q&A are part of the public record. And this meeting is being recorded and will be posted online. Jessica, I assume the recording is started. Make sure it's started before we do any
Yeah,
business.
the recording's in progress.
Okay, great. And feedback is welcome about anything at herc.info@oha.gov, Oregon.gov. So that is our agenda for today. And I'll go ahead with the staff report now. The main item is a report on the benefit update project for those of you who were at HRC in August. This will be very, very familiar, so apologies. But you can also follow up with questions you didn't think to ask or you thought of since that last meeting. Okay, go ahead, next slide. So this is about some changes that are coming to our work at HRC. It shouldn't directly affect this subcommittee. It's more about the prioritized list. But it's good for you all to have awareness as you hear about this work and, communicate with others who are maybe interested. So the Centers for Medicare and Medicaid Services, CMS, did announce in 2022 during our waiver renewal that our waiver authority allowing the state to use the prioritized list instead of the state plan to define amount, scope, and duration of covered benefits will end. Now, that sounds ominous. That's a big change. It's really very specific to the funding line, but it does set off the need for us to make a variety of changes, and we'll get into those a little bit today, and there'll be more to come over the next few weeks and months. Basically, we'll be subject to the same federal regulations as all other Medicaid programs, which use their state plan to define the benefits. We have to align that determination process with state plan regulations and describe the covered benefits in the state plan and related guidance. Now, when it says describe there, that is not at the level of detail that is in the prioritized list where we have very specific codes and very specific criteria. So let's go to the next slide and I'll get more into that. So what is changing? So on the left side of the screen, you see what we have today. Health conditions and their treatments listed in priority order. The greater the population level health impact of a service, the higher the treatment is ranked. And then there's a funding line determined by the legislature, although that's been frozen for the last 12 years. And things below that funding line are not covered, usually in OHP. By January 1, 2027, Oregon will be required to cover all medically necessary benefits within certain mandatory categories in the state plan. This will help OHP meet the needs of individuals instead of prioritizing coverage based on population. And when we say that, well, again, what I'm really referring to here is there can't be a funding line. Things can not be covered, but they have to be for a different reason. Specifically, you keep seeing the word medically necessary there for a reason. It needs to be because of medical necessity. Some medically necessary services, like physician services, must be included by federal law. So if it's a physician service and it's medically necessary, OHP needs to cover it. Others, like adult dental services, physical therapy, chiropractic, are optional, and the state has a little more discretion. And within the scope of the state plan, which includes both some mandatory and some optional services, the plan is for HRC to decide which services are and are not medically necessary based on the evidence and expected expert and public input. So much as the HRC does today in developing the prioritized list, the HRC will be making the decisions about medical necessity in the scope of the state plan. So again, the HRC will be deciding that continue to have much the same role it has today. Guideline notes that provide medical necessity criteria will be continued. There may be some rewording and so forth, but we expect much of that work to carry forward. There will continue to be diagnosis and treatment coding pairs. There may be some consolidation. We may have an opportunity to simplify, since we no longer will need to say that one service is more important than another. It's just kind of a binary of whether it's medically necessary or not under certain circumstances.
Hey, Jason, quick question.
Sure.
On that previous slide, can you just, on that first bullet point on state plan service categories by January 1, 2027 required, is that how other states are, do all Medicaid states or all states in the nation have that exact same verbiage, like North Carolina, California, you know, all
Yes.
those? So we are joining essentially what all the other states are doing. Is that how this?
Yeah, in fact, it's not really clear in this slide set, but we have a state plan today. You can Google OHP state plan and you will find OHP state plan. It defines the broad benefit categories: physician services, hospital services, federally qualified health centers and rural health centers, non-emergent medical transportation, and there's many more. That exists today. That will exist tomorrow. It's our state's agreement with CMS. It's very high level. It does not say anything about specific services like hypoglossal nerve stimulators, for example. That is a different level of detail, and we now have it in the prioritized list. We won't have it in a prioritized list, but we will need to have that level of criteria and detail. Essentially, in administrative rule, like the list is essentially adopted into rule today, it's going to be called something different. We're still settling on the proposal for the language, but the idea is that very similar, there'll be a resource to guide decisions about medical necessity within the scope of those broad categories in the state plan. Does that help, Mark?
Mm-hmm. Thank you.
Okay. And then this is a little graphic. You see the funded region there, and you can see those categories that are in the state plan. You know, most of what we look at HRC is physician services, or like other practitioner services like acupuncturists, chiropractors, physical therapists. I think physical therapy has its own category, but there are some others. But then you see the funding line there, and below the line, it's not funded, not covered, except where the comorbidity rule applies, which I won't get into today. But go ahead, next slide. So what's going to happen is Ariel is already doing the vast task of dividing the current unfunded region and figuring out what of that is going to be newly covered and medically necessary services. You know, what's already covered. Frankly, many of the conditions below the line just need office visits, which are already covered because they're diagnostic. And then unfunded services, which are not medically necessary, and we'll need to develop policy that says that. And those decisions, you know, Ariel's doing the prep work for that, but that will be brought to the HRC, which will make those decisions.
Quick question. Does this mean that there will likely be an expansion of services?
Yes, as a matter of fact, a relatively small expansion, but yes, an expansion.
Hmm.
And I'll get into that a little more. Future slide. Go ahead, Liz. So again, like I said, we're working on a reorganization. The code pairings, again, we'll have the current, we talk about them as lines because they're prioritized and they're in a numeric order, but they won't need to be prioritized, but there still will need to be code pairings to give guidance to the CCOs on what services they need to cover as medically necessary. And we may take this opportunity to collapse some lines. For example, there's a lot of lines that just need, as I said, office visits and over-the-counter medications or other medications. And those, we might be able to consolidate a bunch of lines into a single line to simplify things a little bit. And the other example Ariel gave was there are 20 lines for newborn conditions. Can we consolidate those some? Possibly. So we'll look, those are, I don't think those will have a significant impact on our members, but they may simplify work for us on the team as well as those that are CCOs. So go ahead. So and this looks like I got ahead of myself here. Yes, so the current state, again, we have our lines, diagnosis, procedure code, and then data files and documents containing the guideline notes are published. We'll have these exact same file formats to communicate the information. It's just it'll be somewhat different information and not prioritized in the same way. Likely fewer groups, and all decisions about that will come forward and be reviewed at the HERC with an open, transparent process and opportunities for meaningful comments. So if something we think isn't going to adversely impact CCOs or plans or members, then that's the kind of thing we'll be looking for feedback, as we always do, and we'll make adjustments.
Another quick question.
Sure.
Will this have any impact for actual care in terms of an administrative burden for doctors and clinics?
We're hoping there will be a reduction in that. And there are two reasons for that. One is there's one prioritized list in the world, and people come in from other states, or they don't work primarily with Medicare, Medicaid, and it's just unfamiliar. And two is you get denials because it's below the line. No other health plan does that. And the language will need to look more like what you see from a Medicare or commercial plan, that it's not medically necessary, it's for appearance only, whatever the situation may be, there'll have to be an actual, like a legally defensible reason for the denial other than just the funding line.
Okay, thanks.
And the consolidation may also reduce some barriers. Again, guideline notes will remain largely the same. We may rename them medical necessity policies or something along those lines, replacing the references to lines with references to code groups, which may look a lot like the lines in many cases, and in some cases may be quite different. There's references to lines in the unfunded region. Those may be replaced where appropriate with statement that the services are either not covered in the benefit package or not medically necessary when that's the case, or if they are medically necessary, then there'll be coverage for them. So that's those additional services that will be looked at. And again, Ariel has already begun doing outreach to specialty societies. We met with ophthalmologists last week and allergists this week, and I think we have 8 or 10 more groups to meet with over the next while to identify the different services and say, this needs to be covered because it's medically necessary. That does not, because of the same reasons that we look at things today and say it's not effective, it's harms outweigh benefits, or we need step therapy, or only for patients who meet the indications, things like that. Here's a difference. If you have feedback on any of this, there's an email address there, 1115waiver.renewal@odhsoha.oregon.gov. Jessica, if you wouldn't mind putting that in the chat, I would appreciate it. But that's where they're asking for feedback on this to go through so they can track it through the waiver process. So would appreciate that if that's specific to this project. Of course, if it's our regular business, just use our regular contact information. Go ahead.
Jason,
This-
quick.
go ahead.
quick. On the definition of medically necessary, did I hear that we're talking to groups to regard what they think is medically necessary, or are we using standard nationally ranked documents like we do for commercial or Medicare? That's
Yeah. So
All of the above is the short answer.
yeah, it's going to depend. And
Okay.
there is a definition in rule that you have today and you use for EPSDT at the plans. That definition will be there, although it may get revised and simplified along the way because the reason we have both medically necessary and medically appropriate relates to the prioritized list in a way that I honestly can't keep in my head. But the idea is that may be revised, but there will be a definition. And Jessica, yes, please promote Louis Libby. The other thing about that is that, HERC will be deciding what is medically necessary. As you know, that those definitions tend to have a lot of vague words that people disagree about. And there will be a space in which HERC will decide, much as it does today in the funded region, which services are appropriate and necessary for low back pain or any other condition. It's just we won't have a unfunded region like we do today. And more details to come in the next few weeks on that. I just got some news this week, but I can't share it till next week, so stay tuned. Anything else?
Louis Libby, I need to promote you to panelist. When I send you an invitation, please accept.
Yes, thank you, Dr. Libby. He's one of our appointed experts for this next topic. And you see there a timeline. We're in the summer and almost into the fall next week here, and we'll be collecting feedback. There is a meeting for the CCOs and another one for member proxies next week. And so if you received an invitation to those, I encourage you to attend. And we'll be updating you at this subcommittee and at the HERC meetings as well. And then during the fall, we'll be developing a transition plan. HERC, meanwhile, will continue its public meetings and listening sessions. And if anybody knows something that's in the unfunded region and they want us to look at that and say, no, this should be covered or this should not be medically necessary, we're concerned that this, shouldn't be covered, that's something to email us about. And just like we always do when people bring topics, we will look at it, and it won't all be Ariel because we are hiring another medical director, fingers crossed. So that is our high level timeline. But again, the idea is to have the rates set so we'll know how much it costs sometime in time for the rates to be set for 1/1/2027 and the decisions made so that the code pairing files can and medical necessity policies and so forth can all be ready to make a smooth transition. All right, and again, there's that email address. And yes, I'm happy to answer any questions. There's also a website. If you Google OHP Benefit Update Project, you'll get a web page that has the latest information on it and more, that will be updated going forward. We're going to work on question and answer documents and so forth to address things. All right, that is all for the staff report. With that, I think we can turn it over to our next topic.
So our next topic is the review of the coverage guidance report. And Specifically, you'll see it's about hypoglossal nerve stimulation for obstructive sleep apnea. There is some information in your packet. Hopefully you had some time to review that. I think we're looking at, the question is, should a medical device put in the body, implanted device to treat troubled breathing while sleeping, be covered? So I don't know if you have a presentation, Ariel, or you want me to just review what's in the minutes or the packet?
Oh, for the evidence review?
Yeah, well, I can present that, what the coverage guidance plain language summary that was there. You
No,
can.
we do have a presentation. Our colleagues at Center for Evidence-Based Policy will present.
Okay,
And then Ariel will
please
present
go
after
ahead.
as well.
Thank you.
All right,
So-
good afternoon, everyone. Should I go ahead and get started?
Yes, please.
Okay, thank you. So I'm here today to talk to you all about our evidence review for hypoglossal nerve stimulation for obstructive sleep apnea. My name is Marcus Bach-Huber, and I work with the Center for Evidence-Based Policy, along with my colleagues that you'll also see on this call, Shauna Durbin, Courtney Cooper, Jen Ryan, and of course, Dr. Val King. So first start with disclosure. So none of us have any conflicts of interest to disclose. This slide set is designed for a live presentation with commentary to accompany the full report. So you kind of use it in complement with the full report. The full draft coverage guidance can be found in the meeting materials for today, and citation of studies corresponds with the reference number assigned in the coverage guidance. Next slide, please. So I'd like to take a second to talk about the role of the Center for Evidence-Based Policy in this process. So we are contracted by OHA to carry out systematic evidence reviews for you all, for the HERC and HERC staff. We perform reviews using widely accepted and rigorous methods, and our staff have previously worked with governmental organizations that synthesize evidence. So, for example, ARC and NICE and other state Medicaid programs. We carry out the evidence review according to the scope assigned by HERC. And if we have questions or clarifications, we work with HERC staff. So our role is that we provide the evidence review only to you all, to HERC and commissioners and to HERC staff. And then you all, your job is to translate that into the coverage decision. So we play no role in recommending anything about coverage. Next slide, please. Just like to say a special thank you for our two appointed experts, Dr. Derek Lamb and Dr. Louis Libby. They were tremendously helpful, and we'll talk a little bit about how we worked with them in this process. Thank you both again for your generosity and your expertise. Next slide, please. So we'll start with some background. For abbreviations, we'll go over each of these at first use. This is mostly for people referring to the presentation after the fact. Next slide. So what is obstructive sleep apnea? So OSA is a disorder where breathing is interrupted during sleep, resulted in disrupted sleep, a low oxygen level in the blood, or both, estimated to be pretty common, about 9 to 38% of the population. The diagram you see here kind of illustrates the illness. On the very left side, you have a typical airway where this is a person laying on their back and you're kind of seeing through their head and neck. In this person on the left, they're sleeping and they're breathing and air is moving freely through their nose and mouth into their airway. The person in the middle, you can see those tissues of the neck and throat have kind of compressed the airway a little bit or narrowed the airway a little bit. You can see especially those muscles of the tongue there have kind of sagged back into the airway, and that's narrowed it. And then on the right, you can see that those tissues have completely collapsed the airway and the airway is closed. And that in that instance, there's no air moving to the airway during sleep, which can be very disruptive. Next slide, please. OSA causes a lack of restful sleep, daytime sleepiness, and headaches, among other symptoms, which can be very bothersome for people. It's also associated with reduced quality of life, poor work performance, and increased motor vehicle accidents, as well as cardiovascular diseases like the ones you see there. Next slide, please. OSA is diagnosed through testing in a sleep lab or at home to identify obstructive respiratory events. There's two types of these events. We divide them into apneas and hypopneas. So apneas are a complete cessation of airflow for 10 seconds or longer, and hypopnea is a reduction in airflow of 30% or more for 10 seconds or longer, with a reduction in oxygen saturation by 4% or more. There's different definitions of the hypopnea. The one that the 4% definition we're using is used by Medicare and OHP and other payers. So that's the one that we're going to be using throughout this presentation. The count of these events is called the apnea hypopnea index, or AHI. So when you see me use that abbreviation, that's what that means. And it's classified as mild, moderate, or severe. There's another measure called the oxygen desaturation index, which is also used, and that's the count of desaturations, again, using that 4% threshold. Next slide. So how do we measure patient-reported outcomes? There's several validated questionnaires that assess patients' OSA symptoms, including the Epworth Sleepiness Scale, which measures daytime sleepiness, the Functional Outcomes of Sleep Questionnaire, or FOSQ, which measures sleep-related quality of life impairments. And then there's some general quality of life scales that are used in research, but not typically in clinical settings. Next slide. So the first line treatment for OSA is CPAP, or continuous positive airway pressure therapy. You can see in the diagram here is what CPAP does. It's an external device that creates a positive pressure flow of air through the nose or mouth or both, depending on the device, to maintain that open airway during sleep to allow air to freely move in and out of the lungs during sleep. Next slide. And finally, we get to hypoglossal nerve stimulation. So hypoglossal nerve stimulation is a second-line therapy with one FDA-approved device called the Inspire Upper Airway Stimulation System, and it was approved in 2014. And the device is illustrated there on the right. And basically, it consists of a battery pack or pulse generator. That pack that you can see there on the chest, and there's two leads. One is the sensing lead. You can see there it rests in the intercostal muscle, so that's the muscles between the ribs, and that senses when the person is taking a breath. And the other is the stimulation lead, which is in contact with the hypoglossal nerve in the head. And what that does is stimulation of that nerve causes the tongue to be pushed out with the hope of maintaining a more open airway. So the sensing lead helps to time the stimulation of the tongue with the breath. Next slide, please. So patients who are potentially interested in HGNS kind of have to meet several criteria. The first is it's only approved for moderate or severe OSA. The second is that they generally have to be CPAP intolerant, or their CPAP did not eliminate OSA. And the FDA defines CPAP intolerant as an inability to use CPAP more than 5 nights per week for at least 4 hours per night, or they're unwilling to use CPAP. For example, they return it before they use it. And did not eliminate OSA means that they continue to have an elevated, AHI despite use of CPAP. So if those two criteria are met, or one of those criteria are met, then the person can receive a drug-induced sleep endoscopy, or DISE study. And what that study does is it administers a small amount of anesthesia to mimic sleeping, and then uses a camera to evaluate the tongue position and the tissues of the soft palate and neck. And what the goal here is to exclude those with complete concentric collapse of the airway. By that we mean collapse all the way around the airway, because in those folks, stimulating the tongue muscles isn't going to address the solution, because the solution, the issue is bigger than that. And if that study does not reveal complete concentric collapse, then the person can proceed to implantation and activation, which we'll talk about on the next slide. So implantation is typically an outpatient procedure. The device is healed in place about 1 month after implantation and can then be activated. A follow-up sleep study is required to adjust device settings and optimize the patient's comfort. And the patient has a remote device controller to turn the device on and off. The pulse generator has a battery that must be surgically replaced approximately every 7 to 10 years. Next slide, please. So I'm going to present to you on the FDA approval because it's changed over time, both in this background section, and then we'll talk about it again in the findings section, just because has the potential to be a little confusing, so I just want to make sure we touch on it in both sections. And I'm happy to answer any questions about this at the end as well. So the original FDA approval in 2014 was for folks aged 22 and older, and it had a warning that the device was not demonstrated to be safe or effective in those with a BMI higher than 32. So it wasn't an exclusion or an indication or anything like that, just said that the device has unknown performance in folks above a BMI of 32. And the AHI criteria for that original approval was between 20 and 65. Then there was a supplemental approval in 2020, which decreased the age to 18 or older and decreased the lower limit of AHI to 15. And then most recently, there was a supplemental approval in 2023. And so the currently approved indications are for moderate to severe OSA, folks that are CPAP or CPAP, folks that are CPAP intolerant, or the CPAP did not eliminate OSA. Again, like we talked about, no concentric collapse on that DICE study. Age 18 years old, the upper limit of the BMI warning was moved to 40. And again, that warning exists due to unknown effectiveness or safety at higher levels. And the upper limit of the AHI was increased. So the AHI range is 15 to 100 currently. And these approval expansions were based on non-randomized, non-comparative data as far as we can tell. Next slide, please. So Inspire Medical Systems, which is the manufacturer of the device, maintains a public directory of providers. And you can see the number of providers that we found on the map here. Just to note, this may not be a complete and comprehensive listing of all providers, but this is what we got from the manufacturer themselves. Next slide. Next slide, please. Okay, so we'll talk about the scope and methods in the typical PICO format. So the population, we looked at adults with moderate to severe OSA. So by definition, we excluded children and adolescents, adults with mild OSA, and adults with central sleep apnea, which is a different medical condition. Next slide. We looked at hypoglossal nerve stimulation devices, as I mentioned, and we included any studies involving non-FDA approved devices, but we analyzed them separately. So we didn't include them in our full evidence analysis that you'll see me present, but we have more information about those studies in the coverage guidance itself. Next slide. So the eligible comparators were non-surgical OSA interventions such as CPAP, no treatment, subtherapeutic stimulation, also called sham stimulation or an inactive device. We'll talk more about what that means in a few slides. And we excluded airway surgeries and weight loss interventions. And this is all according to the scope that was assigned to us by HERC. Next slide. The outcomes that were selected were divided into both critical and important outcomes. For critical outcomes, we had quality of life and device-related serious adverse events. And for important outcomes, it was change in OSA severity, daytime sleepiness, and major adverse cardiac events. And as you all may recall, those events were both selected and prioritized by the commission several months ago. Next slide. So then what study designs did we consider? For effectiveness outcomes, we looked for randomized controlled trials of any size and comparative prospective cohort studies of greater than 100 participants. And for harms, we looked for randomized controlled trials and prospective cohort studies as defined above, as well as systematic reviews, single-arm prospective non-randomized studies, and registry studies. And next slide, please. And you may be wondering to yourself why the designs that we included were different for the different outcomes. And so we can break it down a little bit like this. For effectiveness, really the best design gets at cause and effect. And these designs reduce or remove key biases such as selection bias. The gold standard for these studies is a randomized double-blind placebo-controlled trial, but there's other designs that can give strong cause and effect type information for interventions that don't lend themselves to a randomized double-blind placebo-controlled trial. And really here we want to limit or exclude study designs that can't help us determine cause and effect because they're biased. That's just going to add noise to our information and not really help us figure out the true effects. Then when we look at harms, we kind of flip it on its head a little bit. We know that randomized controlled trials are often inadequate to determine safety because they're frequently smaller and shorter follow-up, because they're more complicated and expensive to run. And better designs to look at harms include a large and representative sample with a long follow-up period. The purpose of these studies is to find and uncover the full scope and magnitude of serious adverse events or harms, including rare ones. So some examples here are national registry studies and large cohort studies. But again, we're going to include all data that we have. So it's really kind of the opposite of the first set of outcomes. Next slide, please. So for our key questions, we have what was the effectiveness of HGNS versus non-surgical treatments for OSA? And then what are the harms of HGNS? And then how does the effectiveness and harms of these interventions vary by intervention and patient characteristics? For our contextual questions, the first one was kind of a broader look at some other types of study designs looking at other important outcomes. The second one was on comparative effectiveness, and the third one was on cost effectiveness. Next slide, please. So for our search, we worked with an information specialist to develop a comprehensive search strategy. We searched multiple clinical evidence databases, Ovid Medline, Central, and CDSR, and we did independent dual review of our search results. For policy items, we conducted targeted searches in Ovid Medline, websites of related professional societies and guideline groups, and internet searches with DuckDuckGo. All risk of bias and methodological quality assessments were by dual independent review. Next slide. So you'll see these grade confidence ratings throughout the findings section of this presentation. And this is a way to bring all the evidence together and assess our confidence in the result, basically. And it rates from very low to high. You can see it consists of 4 blue dots. And the more dots that are filled in, the higher the confidence rating. So very low confidence is that the true estimate is likely to be substantially different from the estimate of the effect. Sorry, the true effect is likely to be substantially different from the estimate of the effect. And high confidence is very confident that the true effect lies close to that of the estimate of the effect. And then for outcomes where we didn't find any eligible studies, those are labeled as no evidence. So it's 4 empty circles that are a different color, they're black, just to indicate that there was no data to say one way or the other. Next slide, please. So then again, just want to say thank you to our clinical or outside experts. We really value local clinical expertise. This is an Oregon-based project, and we want to discuss with Oregon clinicians, and it can really improve the quality and relevance of the evidence reviews. And so both clinical experts reviewed and shared feedback to help our review, to inform our review at kind of 3 points. The first was participation in the scoping meetings with the HERC several months ago. Then we met with them first to review the list of included studies and clinical guidelines to make sure that we weren't missing anything. And then we reviewed our preliminary findings and evidence synthesis just this past August to, again, kind of get their take on things, make sure we weren't missing anything. And in all these meetings, we presented our findings and offered an open discussion of any questions, comments, and concerns. And of course, experts were invited to participate in this meeting and invited to invite any colleagues with relevant expertise to participate in the public meeting as well. And again, thank you again for our experts. I know I've said it a few times now, but I really appreciate your time and expertise. Next slide, please. So we'll move on to the evidence review. So this is a flow chart of our search. So you can see we started off with 476 unique citations. We reviewed the full text of 126 of them, and we ultimately ended with 29 publications. Those were divided into 17 studies that were relevant for the KQs. And those 17 studies were described in 20 different publications. And then we had 9 evidence-based recommendation publications. Next slide, please. I want to take a moment here to talk a little bit how HGNS devices were studied in RCTs, because it's a little bit different than other drugs and devices you may be used to. So the method that they use is called the withdrawal RCT. Sometimes it's called a randomized withdrawal study or randomized withdrawal trial. If you hear me use those terms, you know what I'm talking about. But withdrawal RCT, I think, is the most consistent term. So we'll first go over kind of the blue flow chart. The patient can start off having the device implanted and then undergo the healing and adjustment phase. And then if they have a positive response and don't have the device removed, they can be enrolled in these studies and randomized. And when they're randomized, they can be randomized to either leaving the device active or rendering the device inactive or delivering a subtherapeutic stimulation. That's sometimes called a sham stimulation. The purpose there is to deceive the patient, to make them think that they're receiving treatment, but they're not receiving the treatment that would be necessary to really move the tongue muscles out of the way. I see a hand, Miriam. I don't know if you want to ask.
Oh, yeah, thank you.
Yeah.
I just wondered if you could comment on this particular type of study, the withdrawal study, and the confidence that you would assign to this, which is a slightly atypical type of study as compared to what I would think of as a regular randomized controlled trial. Thank you.
Yeah, that's a really excellent question. Thank you. Thank you for asking that. So you can see here through this flow chart that the patients who are enrolled in the studies are typically highly selected. So they're people who had the device implanted and had a positive response, and they were interested and motivated to participate in more research. So that's one aspect of it, which we'll talk about when we talk about the limitations of our evidence, certainly. The other is that the randomization, the withdrawal period for the studies was typically quite short, 2 to 4 weeks. And so we don't have long-term, these RCTs weren't long-term studies. That's another limitation. The other main one is that that green arrow and box you see there, we don't really know the percentage of people that had a negative response or had the device removed. So because that number was never quantified in those studies, they kind of enrolled consecutive participants that met the inclusion and didn't describe what percent met the response criteria. Kat, do you have a question?
Oh, yeah, that's a pretty important data point. It seems like for us to know is how many people made this initial blue versus green cutoff. Is there I guess the other question I have is about implantation then. That's also a procedure that has risks associated with it. And if some unknown proportion are not going to have any response to it, is there an alternative besides implantation that involves like stimulating the nerve, but without creating, without doing the procedure?
Yeah, so I'll address your comment, and then Larry, I saw your comment, which I will get to right after that. So there are other types of devices in development, including external devices, but those aren't in use or widespread clinical practice. I don't believe they're FDA approved. Don't quote me on that, the external devices, but that's certainly an area of development. Typically, these are folks where they used CPAP, it didn't work for them, or they were unwilling to use it. And then that's why they ended up in this pathway of getting an HGNS implanted. And Larry, to address your question, the withdrawal refers to that, those 2 blue boxes after the randomization box. The people all have devices, they all have functional devices that are working, and they've all responded to those devices. So what the study does is it randomizes people to turning the device off, basically. So withdrawing that stimulation and seeing how much worse those people get. And the difference between the people who had their device left on and the people who had their device turned off or to a very low setting, that's what they argue is the effect of the device. So in a regular drug trial, you might give, a drug to one group and compare it to the other and look at how much better the people with the drug gets. This is kind of flipped on its head. Everyone's gotten the device and you're taking it away from certain people and seeing how much worse they got. And that's how they determine the cause and effect of the HGNS device.
And just to call out, just to highlight one more extra time, other studies, let's say like tonsillectomy for sleep apnea, you might have a group that gets randomized to get a tonsillectomy and they're compared to a group that got routine medical care. And then you could get a sense of how that surgery impacted things. This is kind of also turned on its head. So everybody's had the surgery, and the people that it didn't work on are, you've selected for the people who it works already.
So Ariel, what we don't know is, did it work for 5% of the people or 10% of the people or 90% of the people? We don't know the efficacy just blankly across a population.
Yes. Good.
That's correct. Yeah, the studies weren't designed to give you that number. I just want to follow up on one thing you said, Kat. So thank you to Shauna for reminding me of this. So there are the transcutaneous, so the external devices, they were out of scope for us, but we did come across some information about using TENS units. So those electrical stimulation units, there's a pilot trial, but it's not FDA approved or cleared yet. And then there's another device that is device that just goes in the mouth, and that is only approved for mild sleep apnea. So that was also out of scope. So there's no external or less invasive alternative nerve stimulators for this population and this condition that we are aware of.
And then I think what I was kind of hearing as part of your question, Kat, as well, was, is there a way, like when we do nerve ablations for back pain, for example, that you can get like a trial run of something to see if it's likely to be effective before you have surgery? That doesn't happen in this case. Is that your understanding, Marcus?
Yeah, we didn't find any information on that in our searches. So I'll carry on, but if anyone has any questions at any point, please, of course, just put them in the chat or raise your hand. So the big issue, one of the big issues here also is how the outcomes are measured. They can be measured in many different ways. Excuse me. You can measure from, and that's represented by those dashed lines at the bottom of the slide. You can measure from the pre-implantation period to the end of the withdrawal period. That's for the change from their pre-implantation baseline. You can look at the difference between when they were randomized and the end of the withdrawal period. You can look at the end means of the outcomes. You can look at the changes in outcomes. The studies all do it in different ways. We try to present things in the same way and consistently. And if you have any questions about that, please do let me know. Next slide, please. So we'll start with the discussion of the quality of life outcomes. We found 2 withdrawal RCTs and 1 cohort study, for a total of 485 people. The 2 RCTs only enrolled people who had previous implantation and a positive response, again, corresponding to the diagram I showed you. And in our grade assessment, we downgraded competence for 2 reasons. The first was risk of bias, and the second was indirectness. So risk of bias, we found limited methods reporting, found selection bias. This is Mimi speaking to your question, because it's a highly selected population. We also found industry funding and author conflicts of interest. And indirectness, one aspect of indirectness is how applicable is the trial to the broader population that would be eligible for the study. And in this, we found some limitations, that there was both differences between the different study designs, for example, in follow-up period and duration of withdrawal. And the study populations were more limited than the current FDA indication. So research participants in these trials were not necessarily generable to the greater Medicaid insured population that would be eligible for the service. We'll go into a little bit greater detail on that when we get to the guidelines and coverage policies section. And as an additional limitation, short follow-up periods, there were short follow-up periods relative to the intended length of the intervention. That's, again, that withdrawal period was pretty short. So a lot of these limitations are the same for each of the outcomes. So I'll kind of skip over them when it's exactly the same, and I'll point out any differences for the different outcome families. Next slide, please. So for quality of life, we found that there was low confidence of benefit in these 2 RCTs in 1 cohort. And this was comparing HGNS versus control or no treatment. So patients who had received HGNS had significantly better sleep-related quality of life, as indicated by higher FOSQ scores. You can see the scores there. The differences in each case exceeded the established minimal clinically important difference of greater than or equal to 1 point. Next slide, please. Then we'll talk about SAEs, which is, we'll have a little bit of intro material here because it's kind of a tricky discussion with these studies. So we looked for adverse events considered SAEs according to the FDA definition. And the FDA definition includes the SAEs that you see there bulleted, so death, life-threatening adverse event, and so on. And study investigators can also call their outcomes SAEs if they pose a threat of death or hospitalization without intervention. So an example here might be HGNS device revision or explant procedure, because it's a surgical procedure. Larry has a question, if we can back up 1 slide. So where did the points differences come from on the previous slide? So these were from the studies themselves. This is data abstracted from the studies. You can see the 2 RCTs in 1 cohort. Each one is a bullet list. So the first is the first two are the RCTs, and the third is the cohort study, and that's the extracted data. And this outcome was quality of life. Daytime sleepiness, as measured by Epworth Sleepiness Scale, is another outcome which we'll talk about. This was just restricted to quality of life from the FOSQ. That's correct. All right. Does that answer your question, Larry?
Yes, I'm sorry, I was doing it on the video, thumbs up. Thanks.
Okay, good. Couldn't see it there. All right, next slide, please. So we found 10 studies, 2 RCTs, 1 comparative cohort study, and 2 non-comparative cohort studies, 4 registry studies, and 1 systematic review. And they classified SAEs, which we kind of divided them into 2 buckets, and you'll see why. So we first looked at revisions and explants. So revision is if a lead malfunctions, it has to be replaced, or the battery pack has to be replaced. An explant is where it has to be removed. And then we looked at other device-related serious adverse events. This can be bleeding, infection, things like that. When they insert the respiratory sensing lead, the breath sensing lead into the space between the ribs, sometimes it can puncture a lung. I mean, it's called a pneumothorax. That can happen. So that was one of the things that we looked for. So we downgraded competence for risk of bias for both types, and then indirectness only for other device-related SAEs. And the main issue with the other device-related SAEs is that the studies classified and categorized them completely differently. So we couldn't really make apples to apples comparisons about which SAEs were kind of broadly applicable for people that were getting these devices. Next slide, please. So these grade assessments here are going to maybe be a little counterintuitive. So the studies reported actual harms. So we know that these things happen, but what we're rating is the confidence that we understand the full scope and magnitude of the harms. So for revisions and explants, we rated it as moderate confidence that we understand the full scope and magnitude of the harms, because of the reporting on this studies were fairly consistent, and the studies were fairly representative of the population that could be eligible. So the rate of device revisions ranged from 0.4% to 6.3%, and the rate of device explants ranged from 0.05% to 2.4% of participants. For other device-related SAEs, we had low confidence that we understood the full scope and magnitude of the SAEs. The eligible studies really varied widely, as I mentioned, in their categorization and classification of SAEs. So we were really unable to determine an overall rate or percentage of these SAEs based on the reported data. And even among an adverse event that we thought was serious, there wasn't enough information to determine whether it would strictly be an SAE under the FDA definition, for example. An infection can be something that resolves with a week of antibiotics, or it can be something that you're hospitalized for, and there wasn't always that information that allowed us to determine a precise level of severity. Next slide, please. Just want to take a moment here to talk about the recent recall of these devices. So in June 2024, the FDA issued a Class 1 recall for the Inspire 4 implantable pulse generator. It was just for 32 individual devices of model 3028. And at the time of the report, there was no injuries or death related to the recall reported by the FDA. This kind of has 2 implications for our review here. So it's unlikely that the included studies reflect any impact of the recall devices, but there may be future studies that are impacted by this recall. So these adverse events related to the recall may be reported in future studies if they occur. Next slide, please. Now we'll move on to OSA severity. This is OSA severity by measures of polysomnography. We found 3 RCTs and 2 cohort studies for a total of 673 patients. We downgraded confidence for risk of bias and indirectness for the same reasons as the quality of life outcomes. And there's that same additional limitation of short follow-up period. Next slide, please. So for HGNS versus control or no treatment, we found low confidence we had low confidence that there was a benefit. So patients who received HGNS had significantly lower OSA severity, as indicated by a lower AHI-4 and ODI scores across all follow-up time points. Just to note that all studies use the AHI-4 definition, which is what OHP uses, Medicare uses, other payers use, so we're all consistent there. And the differences in 3 of the 4 studies exceeded the minimal clinically important difference of greater than or equal to 5 events per hour. Next slide, please. In one study, they compared HGNS versus patients who received CPAP. So again, people who received HGNS were, by definition, intolerant to CPAP. And so you're comparing people who are intolerant to CPAP to people who can tolerate CPAP. Again, by definition, they're using it. So this isn't quite comparing the different treatments in the same group of people. It's almost like comparing 2 different groups of people using 2 different treatments. So in this study at 12 months, there was no significant difference in AHI4 between the HGNS group and the group that was using CPAP. So one interpretation of this finding can be that if you can't use CPAP, HGNS will result in a AHI that's not really different than if you could use CPAP. Next slide. Moving on to daytime sleepiness. So there were 2 randomized controlled trials and 2 cohort studies for a total N of 611. We downgraded for risk of bias and indirectness for the same factors that you've already seen. And again, the short follow-up period is still relevant here. Next slide, please. We found evidence of benefit with low confidence. So for HGNS versus control or no treatment, the patients who received HGNS had significantly less daytime sleepiness, as indicated by lower ESS scores. And the differences exceeded the minimal clinically important difference of greater than or equal to 2 points in all cases. Next slide, please. So in HGNS versus patients who received CPAP, again, this is comparing HGNS patients versus people who could use CPAP. At follow-up 12 months, there was no significant difference in ESS scores between the groups. Next slide. For major adverse cardiac events, we didn't find any eligible studies that reported on this outcome. Next slide. So now we'll move on to the CQs. So the contextual questions kind of allow us to provide more context for this, the evidence for this intervention. The first one is really around broadening the search for key endpoints, just to add more types of studies that may be potentially less reliable. So we're casting kind of a wider net. The scope directed us to find systematic reviews that included a wide variety of study types. And we identified 1 systematic review, including 17 studies, 1 RCT and 16 randomized studies of all available HGNS devices. And that study had some information on some deaths that happened. So they reported 7 deaths, but none were determined to be related to HGNS. So that was helpful. And we didn't find any eligible systematic reviews that reported any other OSA relevant clinical endpoints, such as fatigue-related injuries, blood pressure control, or use of antihypertensives, or rates of major adverse cardiac events. We didn't find any reviews to help us speak to that. For the second CQ, it was on comparative effectiveness to identify RCTs comparing the effectiveness of HGNS with other OSA surgeries, and there were no eligible RCTs, so no information there. Next slide, please. Now this CQ was about cost and cost effectiveness. So we identified 1 economic modeling study on the Inspire system that included data from a randomized RCT that we included here, and also other non-randomized studies. And that study estimated healthcare costs from the perspective of a payer. We extracted the cost per outcome averted for HGNS and adjusted to 2024 US dollars. So it's important to note that this is a modeling study, so there were several assumptions about the impact of HGNS that were made. For example, they assumed that HGNS reduced heart attacks, reduced strokes, and reduced motor vehicle accidents, but as you heard in the earlier sections, that hasn't been shown in RCTs or other strong comparative studies. Just as a note of caution, the study did not use OHP reimbursement methodology to determine costs, so its direct applicability to OHP is really not there. And in anticipation of implementation of the Senate bill you see there, we did not consider any information related to or derived from quality adjusted life years. We're just reporting the cost per outcome averted. If you go to the next slide. So there's 2 graphs here. One on the left is looking at a 10-year time horizon, and the one on the right is looking at a lifetime time horizon. So on the 10-year time horizon, the estimated cost for reducing a motor vehicle collision that they modeled was $107,000, about $2 million for preventing a stroke, and about $700,000 for preventing a heart attack. On the right, it was about 88,000 for a motor vehicle collision, about 6.5 million for a stroke, and about the same for about 640,000 for a heart attack. Next slide, please. Now we look at the ongoing studies. So the purpose of this is to see if there's any studies ongoing that might have a meaningful impact on our findings. And we didn't really find that with respect to the Inspire system. So there was one RCT of a non-FDA approved device, the Aura 6000 device that's ongoing. There's 3 ongoing non-randomized studies of a non-FDA approved device, the Genio system. There's 1 non-randomized study and 2 registry studies of the Inspire system without any RCTs. And the included outcomes of these studies, they don't really include any major adverse cardiac events, so that's not helpful there. So again, no strong study designs that are likely to meaningfully impact the findings of this review with respect to the Inspire system, which was the only FDA-approved system or device at the time that we did the review. Next slide, please. So now we'll talk about guidelines and recommendations. So I spoke a little bit earlier about the FDA approval for device and the FDA approval for adults, and we'll just go over it in a little bit more detail here. So the FDA approval requires that the person be CPAP intolerant, and their definition is an inability to use CPAP greater than 5 nights per week for at least 4 hours per night, or they're unwilling to use CPAP, and that's their language, or that CPAP did not eliminate OSA. Again, the person had a high elevated AHI even with CPAP. The person can't have complete concentric collapse on that DICE study, that drug-induced sleep endoscopy study. And the person can't have central or mixed apneas greater than 25% of the total AHI. Because the HGNS device it's for obstructive sleep apnea, not central sleep apnea. If the person has significant central sleep apnea, the HGNS device isn't likely to help them as much as if it was only obstructive sleep apnea. And then there's some exclusions here, and some of them are fairly self-evident. Some of them, there's additional ones listed in Medicare guidance, which we have later we can talk about. But the main exclusions here are any anatomical finding that would compromise the performance of upper airway stimulation, such as presence of complete concentric collapse, again. Any condition or procedure that compromises neurological control of the upper airway. Patients who are unable or do not have the necessary assistance to operate the sleep remote, so it has to be turned on and off with the remote, and patients who are pregnant or plan to become pregnant. Next slide. This slide looks, hopefully looks familiar. We talked a little bit about it in the background. You can see the main highlights here is that the age has decreased from 22 and older to 18 and older. The upper limit of the BMI warning was increased from 32 to 40, and the range of AHIs eligible was widened from 20 to 65 initially to now between 15 and 100 in the most recent approval in 2023. And again, these approval expansions, as far as we can tell, were based on non-randomized, non-comparative data analyzed by the FDA. Next slide. So this is an extremely dense slide, and I apologize for that in advance, but I think it's helpful to talk about that issue of indirectness that I mentioned. So in this slide, we look at the main studies that we included for the main outcomes, and we analyze the actual participant characteristics of those studies, and you can see how that compares to the FDA indication. So every column you see here is a study that we included for some effectiveness outcome. And every line is a characteristic, every row is a characteristic about that study. So you can see the STAR trial, that was the kind of landmark trial of Inspire. That was an RCT. The eligibility criteria there under age. The eligibility criteria was age greater than or equal to 22, but the actual enrolled age was, the mean was 54.9 with a standard deviation of 10.2. The BMI range eligible for the study was less than or equal to 32. You can see the mean was well under 30, it was about 28. And the AHI, the range that was eligible for inclusion was between 20 and 50, but the mean was at 30. You kind of go along, you can see similar things, that there's pretty big differences in the inclusion criteria and who actually enrolled. So for the ADHERE sub-study, the people who actually enrolled were about the same age as STAR and the other studies. It wasn't reported their inclusion criteria. BMI, you can see the same findings compared to the other studies, and AHI is similar. So we can fast forward a little bit to the effect and Cardiosa 12 study, which are the other main RCTs. And you can see similar trends. The age was about roughly the same. In the Cardiosa 12 study, the mean age was older than the others, but the eligibility criteria was either 18 or 21. Same for BMI, the range included was 35. Some of these studies recruited people who had their devices implanted in the community. So at that time, the upper limit of the BMI warning was 32. So you can guess that in general, people that had devices were typically at or below that BMI. And then the AHI range you can see there. So in essence, the studies all had differing inclusion and exclusion criteria, but the characteristics of the people who actually enrolled were pretty similar and pretty different than the lower and upper ranges of those inclusion and exclusion criteria. That's the main point I'm trying to illustrate with that slide. We can come back to this if anyone has questions or wants to see it more in depth later as well, but for now, we'll move on. Next slide, please. So for clinical guidelines, we found 4 clinical guidelines. The first was from the VA, then the German Sleep Society, then the European Respiratory Society, and then NICE. You can see the methodological quality there. Generally, when it was recommended as a second-line treatment. The BMI warning was listed as 32 for the VA and the European Respiratory Society and 35 for the Germans. And the AHI range you can see there is the lower range that was consistent with the initial approval. Worth noting here that NICE said that it should only be used with special arrangements, so it's not recommended there. Next slide, please. Now we'll talk about payer policies. The first line is Medicare, and this is from the LCD that we found. Excuse me, this is from the year 2020. HNS is covered with a age requirement of 22 years or older and a BMI less than 35 with a AHI range of 15 to 65. You can see that commercial policies, Aetna, Cigna, Moda, Regents, all have age greater than or equal to 18. The BMI upper limit of the BMI is varies between the plans, as well as does the range of AHIs. Just note, Washington Medicaid doesn't have any information on HNS because the report was pre-FDA approval in 2012. So that's kind of expected.
And Marcus, this is Mark. Do we know what other Medicaid payers cover for adults for this device?
No, this is the only coverage policy information that we pulled.
And why did we not look at other Medicaid payers for coverage?
This is so typically when we're doing these reviews at the center, we pull Medicare, the commercial plans in Oregon and Washington Medicaid, and that's the extent of the coverage policy that we do. Okay, coverage policy review that we do.
Okay, so it's comparing Medicaid to commercial.
It's providing a broad overview of the payer policies relevant to the state of Oregon is, I believe, the rationale behind it.
Okay.
Next slide, please.
I have a question about this.
Yes, sir.
How do Aetna, Cigna, Moda, Regents, what's the basis on which they determine to pay or not, to cover or not cover something like this? Do they have their, what do they do a similar type of review?
It's a black box. They don't have any public process.
Yeah, I couldn't speak to that.
Yeah,
those are commercial entities.
But Mark Buchholz, if when this ends up coming to VVVS, HERC, those other things, if you want more information on other Medicaid coverage policies, I can reach out to other Medicaid programs and ask.
Great, thank you, Ariel. Thanks.
Okay, we can go to the next slide, please. So here for the discussion, I will kick it over to Ariel. Thank y'all.
Thank you, Marcus.
Ariel, before we do that, we do have Dr. Libby here, and I thought I might introduce him, one of our appointed experts. Don't believe Dr. Lamb was able to make it today. But
no, he's here. He is
Actually,
here.
Jason, he is here. He
Okay,
came a
great.
little bit later.
Then I see you. I see you. Thank you. I will read both of their bios, and then, if along the way anybody has questions for them, feel free to ask. So Dr. Derek Lamb is Associate Professor of Otolaryngology at OHSU. He is the Surgical Director of Dornbecker Aerodigestive Clinic, where he manages complex aerodigestive disorders in children. Additionally, he's the Surgical Director of the Upper Airway Stimulation Program, focused on nerve stimulation to address adult obstructive sleep apnea. He directs the NHLBI-funded research focused on the diagnosis and surgical management of pediatric obstructive sleep apnea. He has no conflicts of interest to disclose that meet HERC's disclosure threshold. Dr. Louis Libby is a retired sleep medicine specialist practicing 1985 to 2021 within the Providence Health System and the Oregon Clinic. He is board certified in sleep medicine, pulmonary medicine, critical care management. During his practice, he treated many patients with obstructive sleep apnea and has no conflicts to disclose. So thank you, Dr. Lamb and Dr. Libby, for assisting us with this development of this and being here today.
Yes, thank you for coming. All right, so this is the current staff recommendation based on the fact that there was a clinically significant improvement in sleep-related quality of life, and Veterans Affairs, CMS, sort of those types of models were covering HGNS, although there are some staff concerns that remain about the studies and the study models. Overall, staff felt that the evidence supported coverage, but it would be in line with the actual study populations, not the FDA approvals, that would recommend hypoglossal nerve stimulation for adults 21 and older when they have a sleep study showing AHI between 15 and 65 using the 4% oxygen desaturation threshold. If any of you are familiar with sleep studies in AHI, there's some debate about whether it should be 3% or 4%. HERC has in the past chosen to use 4%, so that's what we use throughout. And also predominantly obstructive events, a BMI of 32 kilograms per meter square or less, and they have to be non-responsive to CPAP, defined as documented by a sleep specialist of being unable to use the CPAP or have a lack of adequate response to CPAP therapy. They need to have a drug-induced sleep endoscopy consistent with the absence of concentric collapse of the soft palate. I want to note here that currently drug-induced sleep endoscopy is not a covered service for OHP. So if you, depending on where this coverage guidance and recommendations go, if there's a desire to move toward coverage, we would need to also move toward coverage of the drug-induced sleep endoscopy. And then no other anatomical findings that would be a problem or other contraindications to the device. Questions with that? I kind of briefly summarized the rationale before I went into the recommendation. Basically, it's kind of hinging on, I'm sorry, could you go back a slide? It's related to the sleep-related quality of life. In these studies with this highly selected population, it appears that the benefits outweigh the risk. And again, the inclusion criteria were what were in the reported studies. Next slide. We have low confidence that there is this clinically significant improvement in quality of life in select patients. It's low because of the study selection bias and indirectness. And with that study design that's a little bit atypical where everyone had initial positive response, we do feel that we have a pretty good handle on the harms, and in the studies and the reported populations that have been studied, the benefits do appear to outweigh the risks. Next slide, please. Allocation of resources. This requires a high level of resource use. You would have to have a surgical procedure, the drug-induced sleep endoscopy, which is an invasive procedure requiring anesthesia. Then you would need the implantation, which is an additional surgery with anesthesia. And also in lab sleep study follow-up. Long term, we are, this is a newer technology, so it's a little unclear about battery replacement, lead replacements, all of those types of maintenance that would be required, but we're assuming there will need to be some at some periodicity. If a patient can tolerate CPAP, but they're just not getting adequate response to it, then they would need to continue CPAP therapy. So you wouldn't get sort of that cost playing off of it. And there was one economic modeling study that didn't find that there was a cost savings based on sort of the downstream prevention of major things that would cost up the system quite a bit to deal with. I think that's a lot. Oh, values and preferences. This was another strong consideration. Many patients who haven't responded to first line OSA therapy would likely value some type of second line therapy that would reduce their symptoms or improve their quality of life. However, there is going to be a group of patients who would not want to have a surgical procedure, particularly if it may not eliminate their need for their CPAP. The other consideration is that when patients can't tolerate CPAP or they don't get sufficient response to CPAP and lifestyle modifications, there isn't really a lot out on the market that would be additional treatment options for them. Dr. Lamb, I see your hand up.
Yeah, I just wanted to, you had mentioned you weren't sure about the long-term maintenance related to the device. So the battery does need to be swapped out about every, roughly 8 to 10 years, but none of the other equipment pieces in theory should need to be replaced. But the battery part is in the IPG, so that's the main part. But the wires and the leads coming off should not need to be replaced unless.
So it's similar to like a cardiac pacemaker.
Yeah, very similar. Yeah.
Questions for me or for our experts?
Ariel, this is, oh, Kat has her hand raised. Go for it.
Yeah, I'd love a question for the experts in terms of this, where we run into of being unclear about what percentage of people are actually going to respond to it at all or not. It looks like this is a $30,000 to $40,000 device with some level of serious adverse effects, and we're not. And maybe the STAR study said that a third of people won't respond, but I don't have a sense of like what the right number is, and I just wonder about doing what is a slightly invasive procedure when we don't know how many people are going to respond positively to it.
Yeah, well, I'm happy to respond to that. I mean, I think it is fairly consistent across several studies that it's about 70%, between 65 and 70% that are initially of people that are initially going to be responders to the therapy. Now that doesn't mean, and this is exactly how I counsel patients when I see them, that doesn't mean that in that 30% of folks that aren't initially considered to be good responders, that it is hopeless for them, that they won't get benefit from it. It just means that there's potentially more work to do. And part of that includes, adjusting the device settings to see, what would work better. There's sort of a troubleshooting algorithm we go through that involves basically like seeing them in clinic and activating the device when they're awake with a scope in place so it can actually see what impact it's having, the stimulation it's having on their airway, and seeing if under direct visualization can further optimize the device settings to better, address their particular airway, because there are different configurations of how it can stimulate the tongue, and sometimes different configurations work better with different people's bodies, their particular anatomy. And so in the end, I mean, still, it's not going to be 100%, of course. I would guess you get maybe another 10, 15% of those, so that in the end, it's maybe up to about 80% of people that, I think are good responders. I can tell you that in my own experience, I think it roughly mirrors what's in the literature. Like I've definitely had to go through that sort of troubleshooting algorithm with a minority of those patients. But And there are probably some of those folks within that 30% that are just not using their device. I've only had one person ask me to take it out of the, I don't know, probably 50, 45 or 50 that I have implanted. So I haven't done a huge volume of them, but I have partners here that have done more at this time. And as far as I know, they've not had to explant any yet. But to be fair, I'm not regularly checking in with them either. But personally, I've only had to remove one or had a patient request to remove one.
And Lou Libby here, I would just reinforce what Dr. Lamb said, and he certainly has more clinical experience putting these in than I do. I have no experience putting them in and very limited experience seeing patients with them since I retired 4 or 5 years ago. But I would agree that probably from my experience and talking to a number of my partners, probably a third of patients absolutely love it. Another third are pretty happy with it and think they have benefited from it. And there's a third who probably aren't terribly happy with it, don't think it's done what they wanted, or a little bothered by it, and that needs more adjustments. The only thing I would add to the review is there is one other treatment that should be considered in some of the patients before they get the hypoglossal nerve stimulation, and that's a dental appliance, usually made by a dentist and used to pull the jaw forward. It's only effective in people with mild sleep apnea or moderate sleep apnea. So the moderate group might be overlapping with some of the some of the patients who would qualify for the HGNS, the people with an apnea-hypopnea index between 15 and 30. Over 30, the dental appliance does not work, but that usually goes into the options offered to patients with that severity of sleep apnea.
I see Mark and Mimi's hands up. Mark?
I do want to bring up a concern is the data for the quality of life studies that as far as has been presented, this device does not prevent physiological changes in the future or harmful effects to the body, like cardiac or respiratory, but they feel better. Currently, there's multiple guideline notes that we do not cover surgical procedures that make people feel better, such as laminectomies or ventral hernia repairs. They need to have a actual physiological need. And so my concern is using quality of life studies in this surgical where we don't use quality of life for other surgical procedures.
Would you like me to give my thoughts on it? I mean, perhaps we could see what Dr. Libby thinks about that, but I would argue that is perhaps too high of a bar. I mean, you could certainly make the argument that the existing body of literature perhaps doesn't have enough long-term data to support those sort of downstream consequences of the sleep apnea. But certainly, you saw the one study that I think Marcus presented that suggested that it's at least equivalent to CPAP in terms of treating the sleep apnea. And, there is plenty of data that shows that among people that are compliant with their CPAP, those are the ones that you do get downstream benefit in terms of preventing cardiovascular events and so forth. But if you look at real world performance of CPAP, and multiple trials have been done that reflects people's non-compliance with their CPAP, CPAP also has no effect on long-term, on average, on long-term cardiovascular events. Yet that is still the first line treatment and covered by every insurance provider, et cetera. And so, I think if you sort of look at only the people that are compliant with CPAP, I think that shows, at least conceptually, that treating sleep apnea does help with downstream cardiovascular events. And you could argue that a surgical treatment like the hypoglossal nerve stimulation, if it is really equivalent to CPAP in terms of treating the sleep apnea, may be more effective than CPAP in the real world because people are far more compliant with it, at least the ones that are responders, right? And there is plenty of data to show that those responders, I mean, maybe not in this review, because again, this only looked at RCTs and comparative studies, but if there's ample data that shows that people that do respond have very good compliance with their device, even 5-8 years later. So, and that is very different than CPAP for sure.
Yeah, Larry Lyon here. I've got a question for
Actually,
Dr.
Mimi's
Lyman.
ahead of you, Larry.
Oh, sorry.
Thank you. So this is a question. I know, Marcus, you talked about that there didn't appear to be a lot of ongoing studies. One of the things I'm curious about is, however, if there is any data being collected about who might be better candidates for this procedure, or in other words, more likely to be responders? Is it people who either have higher Epworth sleepiness scores, or are they people who anatomically have something that can be identified when with the sleep-induced endoscopies? Because it still seems like, again, true, CPAP is effective for people that are able to use it, for 4 hours or more, 5 days or more a week. However, it is significantly less risky than interventional procedure. So I think that we need to kind of, I'm just curious if there is anything that is like pointing in that direction, which would make this procedure perhaps be a little bit better, be able to possibly have better criteria for who might be a good candidate.
Thanks, Mimi. That's a really good question, or really interesting question. So there's a large, and I'm sure our experts can talk a little bit more about this too, but there's a large ongoing prospective study called the ADHERE Registry. The limitation there, so it's a wealth of data about people who have HGNS devices. The limitation there is there's not really a comparison group enrolled in the study. There are some sub-studies that have gone and found a comparison group, and those are included here when they're eligible. But the reality is that we don't have a lot of comparative data for people that have devices versus people that don't, to further guide our understanding of who responds best compared to people who don't have the device or whatever. So I think the eligible, as far as I can tell with the ongoing studies, the eligible studies that we found are the ones that we are going to have for the foreseeable future. And I hope that answers your question.
It does. Thank you. I mean, not the answer I wanted, but yes. Yeah.
The one exception is that there's and I'll turn it over to our experts, so I'm sure we'll have more color commentary here, but there's a non-FDA approved implant that has an ongoing study that won't change the results of our review on the Inspire system, but that study may become FDA approved at some point in the future. That would be the only impact.
I mean, I think that I'm sorry, go ahead.
Yeah, I would just add that, CPAP was first described about 1984, 1985, and it took many, many years and large databases to imply, they weren't randomized controlled studies, obviously, but to imply the advantages in terms of morbidity, mortality, cardiovascular difficulties of patients who are on it. Initially, we thought that it would help hypertension and get people off of drugs, and it didn't. And there are some patients who certainly are on fewer drugs because of CPAP, but a lot of patients, it's just too late in their many decade history of sleep apnea and hypertension for intervention like CPAP to quickly change that. And it's going to be the same with the HGNS. I have no doubt that the patients who tolerate and use HGNS will benefit the same as people who use CPAP on a regular basis in terms of obviously quality of life. I think the studies are very clear there. But I think in addition, in other ways, just like CPAP, but it's going to take a long time to prove that. And it may be more difficult to prove that because it is a surgical intervention.
Yeah, the only comment I had about, I mean, we're constantly trying to figure out, what are better predictors of repeat and response, right? And I think there is some more recent data since the initial STAR trial and others that have suggested that even the concentric collapse issue is maybe even not the best predictor. I think there's more recent data that suggests that just pure lateral collapse of the or not the soft palate, but the oral pharynx itself may be a bigger negative predictor of response than the concentric collapse of the soft palate. So personally, when I'm doing the DICE to try and evaluate that, that's one of the things I look for as well. And I counsel those patients that I don't think this is a great option for you based on this, even though technically it's not really concentric collapse, but because the initial STAR, that criterion for the STAR trial came from one of the early trials before that was based on an N of 6 patients that had concentric collapse that were found to be non-responders. They carried that forward into the STAR trial in order to try and maximize their chances of success, so to speak. But there has been plenty of grumbling and discussion in the literature about that maybe that particular anatomic criterion maybe isn't the best one, at least as a negative predictor. So, but that just shows you that there are certainly other anatomic considerations besides just the soft palate collapse, or circumferential soft palate collapse. But that is one that we look at, so for sure.
Yeah. I do want a quick response. My thought process would be, although for CPAP, it takes a long time to show results if they are there. For example, if, say, 2 out of 1,000 were helped with CPAP, and those same people used this device, but we had a 4 out of 1,000 had a complication from, say, general anesthesia, a DVT, an infection, then we would say that using this device had worse outcome than not. And I guess that's a concern, that we don't have studies that demonstrate that it is more effective.
Yeah, I mean, that's certainly a reasonable, consideration. I recognize that this is going to be there's greater risk with this kind of a surgical intervention than with CPAP. But again, I would say that that's where, you just have to, as long as they can have some kind of a surgery, like they're safe to have surgery in general. And we always go through an extensive, pre-op evaluation to answer that question. Generally speaking, this is not a, super, we don't see a ton of bad complications related to this, is I guess what I'm saying. I mean, it's an outpatient procedure. It takes about an hour and a half to 2 hours, and the vast majority of people do fine afterwards. The biggest consideration is really just did it work or not, but it's not a zero complication rate, of course, and so that is a fair consideration, no question. I would say I have talked to plenty of patients that have had issues with their CPAP as well that extend beyond just like they had difficulty tolerating, like skin breakdown and so forth. I mean, so that's not entirely without complications either, I guess is my point.
Larry, I know you had a question, and then I see Linnea has a hand up.
Yeah. So I'm curious. So in light of what both Dr. Lamb and Dr. Libby have just said, and also that commercial insurance does pay for this, I'm wondering if both of you could comment on the type of evaluation we're doing now and what the commercial insurers did, and how did they I'm just wondering how they came up with their decision, and did they do it in a similar type of way that we are doing it now? And I realize it's a black box, but I'm wondering if you have any comments about that.
I'd be glad to comment. It's been more than 10 years, but I was a consultant for Regents in regards to various sleep issues, sleep studies, indications for sleep studies, indications for various surgical procedures, not this one. This is going back more than 10 years. And indications for CPAP, things like that, and the dental process. And they would put together a position paper. Frankly, they weren't nearly as evidence-based or as thorough as what Dr. Bachhuber showed us. But they were thoughtful and they had a position paper and they'd say to clinicians, okay, here's our position. If you want to do uvulopalatopharyngoplasty, which is an older procedure for sleep apnea that's not nearly as effective as HGNS, here are the indications. And this is what you have to prove before you do it. So they do have position papers. So their medical directors can say yes or no to various things. And I'm sure they went through something similar with the HGNS. I just haven't been involved in it.
Okay, thank you.
I agree. It's a black box, so I don't have firsthand knowledge about exactly how these different payers are evaluating things. But I know that, you know, I was for many years on our American Academy of Otolaryngology Sleep Disorders Committee, and we do get sometimes asked to review their policies about whether or not they're going to fund something, these different payers, and to comment on it. And so that's at least part of their process where they will have like our official academy sort of input on their funding decisions and stuff. So I don't know how extensive of a, you know, evidence review they go through, but there is at least some sort of external like seeking of comment and stuff from people who are in the field and so forth. So, you know, there is a process most of the time. And I guess I also wanted to bring up another point that it is maybe just one for consideration for this committee, because, you know, right now one of the first questions I ask when people come to me, like there was a time when I didn't even see any patients who had Medicaid because there was no point, right? And I will see them now, and only to consider other types of like surgery, including the modern versions of the UPPP that Dr. Libby said is maybe not as effective. I would dispute that. I think it has to do with patient selection. But anyway, the point is that there may be sort of an equity issue here too, because the people who are on OHP can't even they basically have no access to this type of treatment where people who have commercial insurance do. And that's one of the first questions we ask. And, you know, for a long time, I wasn't even seeing these patients in clinic because, well, there's no point. We can't do anything for you. So, you know, you could look at it as sort of an equity issue too, when it comes to, you know, access to care and access to treatment that many people who have commercial insurance do have right now, and people who have OHP do not.
Thank you.
Linnea?
So I'm just curious, when we think about this, if we think about what the potential volume is, I'm thinking about, and I think that goes back to that inability to quantize who gets the efficacy. I heard Dr. Lamb, I think, say he thought that, you know, 2/3 or 70% of people who you've treated have had some efficacy from it, but we don't have any objective evidence that shows us that at this time. And I'm curious now, CPAP is often, seems to me, prescribed in primary care a lot more often now than somebody needing to go to a sleep specialist. So how are people self-selecting, or how are those referrals happening when somebody gets referred in? So I'm thinking from some systemic points of view, how much information do we have? But I do hear the comment that Medicare and commercial services, the VA, DOD, and others are covering this. And I do know that most of those organizations, as well as the payers we talked about, do a rigorous study before they make a decision to cover something, because their benefit is, they need to manage their benefit. But I'm just curious still how many people we think this is going to affect in the OHP population. I don't know that we can get a handle on that right now.
I think that's an excellent question. I don't think we have an answer. I think the numbers of people with obstructive sleep apnea is enormous. You saw that initial estimate, I think it was 9 to 36% of the adult population. But I've got to admit that a large percentage of those probably are mild sleep apnea, meaning they have less than 15 events per hour. But even taking that into account, there's a lot of people out there. Now, the criteria that have been proposed here is going to limit it a little more because the BMI needs to be, I forget if it's less than 32 or 32 and less, but that will limit the population a bit. As the BMI goes up, the severity of sleep apnea generally goes up, but there's a lot of people with BMIs of 25 who have very severe sleep apnea. But that also is going to limit the number of people who qualify for this. The other thing that was put in, or the other provision in the recommendations, was that before having the surgery, the patient have a proof of a lack of an adequate response to CPAP therapy as determined by a sleep specialist. Somewhere in there, I forget the exact wording, but just to make sure they've had every possible chance to tolerate and benefit from CPAP before they go on to this surgery. So that's also going to make sure that the patients aren't, the concern I've heard from some of my colleagues that the patient goes to the primary care physician, they have symptoms of sleep apnea, they get referred for a sleep study, usually a home sleep study, they get a report, the primary care physician says, let's try the CPAP, the patient has a bad experience, goes back, and then may go to a surgeon potentially. So they're concerned about that possibility and want to make sure patients have a very thorough evaluation before they, and trial of CPAP before they go to a surgeon.
Yeah, and I certainly have no issue with that. I would agree that they need to have at least tried the CPAP first. And I have seen some patients that have come to me and been referred by, their PCPs that have just like, well, there's no way I could tolerate CPAP, so that's not even worth trying. Why are you wasting my time with that sort of thing? And it's like, well, you really don't know till you tried. And I think, as you guys are alluding to, I think appropriately, like with the risk benefit, like you might as well try it and see, because we know that if you can tolerate it, this will work and you don't have to consider a surgery, et cetera. As to so I totally agree with that sentiment. As to the question about quantity and numbers, that's such a hard question to answer. I can tell you that there is huge unmet demand for a surgical option for people that have failed CPAP. And mandibular advancement devices, Dr. Libby was also alluding to. And I do always recommend that to patients that seem to fit the right criteria for that as well, if they haven't tried one. But of course, the main challenge with those devices is that those are the best custom-made ones that are made by a dentist are generally not covered by insurance. I'm pretty sure they're not covered by OHP. So then, and they typically cost anywhere from $2,000 to $5,000. And for many people, that's just out of reach. Or more, right? And there's no guarantee that's going to work for them. And so that's a huge gamble for many people that they're just not willing to take, understandably. So separate from that, I think that there are many people that just cannot tolerate their CPAP, have been prescribed their CPAP and have given up on it, or it's sitting in a closet. I mean, that's almost every patient that I talk to is like that. There's a smaller percentage that are like, yeah, I do fine with CPAP. In fact, I can't live without my CPAP. I just hate it. And for those patients, that's always a much harder discussion, right? Because I can't really say, well, hating it is not a good enough reason. It's like, oh, but I like to travel all the time. I like to go camping all the time, and I can't take my CPAP with. I'm like, well, sorry, lifestyle reasons are not a good enough reason for most insurance carriers. Anyway, et cetera. So, but the vast majority of the patients that I talk to, that is not the case. It's just that they have tried and they just can't do the CPAP. And so you have to think of like, what else can we offer them? If you guys don't want to cover this, and that's a whole separate discussion about other surgical interventions, then they're kind of stuck. And that's kind of where I'm coming from. And so I don't know what the ultimate numbers are from this, but I feel like there's a huge unmet demand for it. And I keep a lid on how many patients that I see, because I'm primarily a pediatric guy, but the select on infusion, yeah. I'm primarily a pediatric guy, so but if I wanted to, like, if I just threw the doors open and said, all right, sign up everybody, like, my clinic would be full of all patients that are like, failed CPAP or struggling with their CPAP and looking for another option. I mean, when I was seeing them more freely, they were booking out like easily 6 months or more. And we've been looking to hire somebody to do sleep surgery in our department. I mean, I have one other partner that has started taking it on, but she's not trained as a sleep surgeon. She's just sort of learning it on the job. But we've been trying to recruit a fellowship trained person for years now because there is this unmet demand. And I'm hoping that in the next couple years we will have somebody.
I would totally agree that in my experience, there are many patients who would like to tolerate their CPAP, can't tolerate it, and are looking for an alternative. No question about that.
Well, I appreciate the clarification. I didn't realize they're covered on OHP. Maybe it's just other insurance carriers then. Is that new? Oh, I'll have to give a look into that. Well, I'm happy to start referring people to go get their devices then. One other thing just to mention on that, there are plenty of people that have tried an oral advancement device, mandibular advancement device, and then found that they didn't tolerate it over time because of, pain to their jaw joint or shifting of their teeth. And then, so even if they responded from a sleep apnea standpoint initially, then they end up not using it for that reason. There's always reasons that people won't tolerate it, even if it does work for them.
I totally agree. It's worth a try, but again, it's not indicated for people with severe sleep apnea, those who have more than 30 events per hour. And that's probably a majority of the ones that a surgeon like Dr. Lamb sees.
So, though I would say that some of that is also just patient selection. This is where when I do the sleep endoscopy evaluations, I'm not just looking for whether or not they're Inspire candidates. I'm really trying to evaluate all their treatment options, including a mandibular advancement device. If they haven't tried one before, I will try and simulate what I think that might do for them to see if that is an option for them as a non-surgical option. So it's getting into a separate discussion, but I feel like that the drug-induced sleep endoscopy is a key role in my sort of counseling of patients. And I mean, I know you guys aren't covering that, have decided not to cover it because there's not enough data, et cetera, et cetera. But that's one of the things I look at too.
There's another consideration. I'm looking at an article from Sleep Science from 2021, Public Health Burden of Obstructive Sleep Apnea, and in the abstract, it states that the economic burden of motor vehicle collisions related to obstructive sleep apnea alone is significant, estimated that 810,000 collisions and 1,400 fatalities from car crashes in the United States were attributable to sleep apnea in 2000. So I think that this is not, although we've addressed this, the motor vehicle crashes as part of a contextual question, because this can affect other people, it does affect other people. In my mind, it's not just a personal health issue, it also becomes a public health issue.
Yeah, unfortunately, Larry, we've looked to see whether or not this treatment can actually affect things with harder outcomes like car crashes, and there is no data on that. So
right.
We also want to call on Mark, who has his hand up.
Yeah, and I do want to comment on the equity issue because we're very concerned about equity. It would be a challenge to compare Medicaid to commercial to Medicare. They're really apples to oranges. For example, commercial will cover ventral hernia surgery, lipoma surgery, laminectomies, spinal fusions, all for much different qualifications or criteria than Medicaid. And for all dollars that are taken away, say, for example, for this device, those would be taken away from other devices or other procedures that could be more effective for our Medicaid population. So that's what I'd be concerned about. And that's what I raised that concern with the previous slide when it compared it to other commercial plans. Commercial covers far, far more things than Medicaid does.
Yeah, I mean, that's a totally fair point, and I obviously cannot claim to have any concept of the sort of different sort of prioritized choices that it has to be made in terms of funding. That is a briar patch for sure. But I think that the last point is a fair one. You know, I think the sleep apnea it is a public health issue, I think. And, you know, obviously I'm biased about the need to treat it and best ways to treat it. But I think that if you could make even small changes on the margins of some of those people that could benefit from this, you know, that could have a lot of downstream effects. I'm glad you reminded me though because Dr. Libby mentioned something about the BMI cutoff here. And I think this is just food for thought. And I don't know to what extent you are willing to maybe consider changing that cutoff, but if it is what it is, then that's fine. But that criteria as it was originally taken from the STAR trial is pretty, like, that eliminates a lot of potential patients who have a BMI over 32. Now that probably does make it so that the ones that you're implanting have a higher chance of success because there's just less soft tissue you have to fight against. But at the same time, I think is perhaps, I mean, it was hard. Like, I don't know the percentages exactly, but it felt like that the majority of the people that I was seeing just were not candidates just based on that alone. And it's, you know, I would just say, all right, this is your target weight. You have some weight loss to do, and then come back when you can get under this threshold, and we can reconsider. I think that's maybe too low. You know, it's most insurance carriers now, the commercial ones you were mentioning, are at least up to 35 on their cutoff. Some of them are as high as 40. I think that's probably too high. But to me, around 35 is a reasonable cutoff. Just food for thought.
I would concur with Dr. Lamb. There's obviously different criteria in the different studies that were reviewed today, but some of them did have upper limits of 35. I have not seen any data or well-controlled data with groups that go up to 40. So 35 seems reasonable to me. 40 seems a little high.
The European studies, German studies definitely went up to 35 with their data. So, and their outcomes are very similar with people under 32.
And Dr. Line, I see your question in the chat. If this procedure is approved and DICE is not covered, how will patients be able to get it? And the answer is we have to consider whether to change that.
Yeah, that is a very good question. I don't think there's any way to get around that. You would just have to be willing to approve the DICE in order to approve this, because that's in the FDA criteria. That's in every single study. Like you can't, there's no way to get around that. If you approve this, then you're going to have to go back and approve the DICE as well. And as I was saying, I mean, I obviously I'm biased, but I feel like that gives me the best sense of what the patient's anatomy is in a manner where we are really trying to simulate what happens during sleep. It's a completely different sort of evaluation than anything that I can do with an awake patient in the clinic. And I think gives me just a much better sense of what their anatomy looks like and what are reasonable things to consider as treatment options. And it's not just about looking at whether they're Inspire patients or even surgical candidates. Like I said, if they haven't tried a mandibular advancement device and they don't have like a history of TMJ or something that might preclude that, I definitely have recommended that many times to patients to go try and get one and see if that helps. And they're in the mild to moderate range.
Appreciate that. I want to make sure that everybody's gotten a chance to ask the questions that they need to ask of our experts today and of our presentation. And if we are thinking are we in a place where we want to proceed to thinking about whether we can consider this or recommend it to HERC or not? Or are there people who need further discussion? Okay, so I'm not
I don't know if you can see him. There's a couple of hands up, Linnea.
Hands up.
Kat Livingston, I saw Kat's first, and then Deb.
Yeah, I actually have sort of an unrelated procedural question about the coverage guidance. So I reviewed our minutes in terms of what were critical outcomes and important outcomes, and I had thought that we landed on MACE remaining a critical outcome and quality of life being important. That was one of the things that was documented as I was advocating for the minutes, just from like not specific to this coverage guidance, but as an overall approach of this committee, maintaining sort of like what qualifies as critical versus important, but in the draft, it looks like that was switched. And I would just like to understand, was that a decision? I would like to understand that, was that a formal decision that was made in which we switched around the outcomes different from what's documented in the minutes?
So I can speak for the center, which is we executed the scope that we received from HERC. We didn't change anything. And my recollection of the discussion was that quality of life was put as a critical outcome. And MACE was moved to important. But that's me, and I may be mistaken. But again, we at the center, we executed the scope that we received. We didn't change anything around.
We need to go back and check that out and follow that through. Yeah.
Dr. Livingston, just as a 30, the EBGS had approved it, the scope and the way that you remember it, because you're part of EBGS, but when it went to HERC, they had made that decision. And they kind of have the final ratifying, say of changing it, approving it, and sending it off to CBP for development. So that's why, and it doesn't typically come back to EBGS, it just goes on to development. So you are astute in catching that change.
Thank you. Appreciate that. Yeah, it would be important for us to go back and look at that. But I do think that you're correct that what EGBS decided and what HERC decided were two different, there was an inversion there. So appreciate you bringing that forward, Kat. Was there somebody else with a question?
I had some big picture questions or kind of a little bit more understanding about, I'm curious on two parts. What kind of setting, hospital setting, clinic setting would be required for this, and then also for the battery change? And are those in the mains? Is that going to be in the main metropolitan areas, or is this something that be smaller hospital settings would also be able to do? And there may not be that much need, so maybe it's not even an issue in making decision. The other question was age. What happens if risk factors increase with age?
Marcus and I know at the center had done just a brief look at availability. I don't know if you have that slide, Marcus, about the state, but there were several centers in different places in the state.
Yeah.
With at least providers that Inspire listed as being providers of the system. Whether or not they're actively doing them, we don't know.
Yeah, that's slide 16 there. There you go.
Yeah. I don't know what kind of volume those other places are doing at this point. I think we have still, as I understand it, we are still the leading provider in the state. I was actually the first surgeon to start doing them in the state of Oregon, but now I've been there. Some of my partners have done more than I have, and I'm sure there are others in other places that have done more now, because I don't do them in super high volume, as maybe some places do. But you do need to have, sort of a network of sleep medicine providers who are familiar with the long-term sort of programming, because they're the ones that are actually tasked with the follow-up and the programming and adjustments of over time as needed. And at times that has been proven to be and also the initial titration study where they'll like do a sleep study and adjust the device settings during the sleep study, kind of like a CPAP titration. At times that has been a challenge even here in the Metro Portland area to find people that are willing to take that on. But I think that so some of these providers that were listed on the Inspire website, I don't know how active if they have run into similar challenges of finding sleep medicine providers as partners. And I think part of that has to do with reimbursement, because like those sleep medicine providers many times have not felt that it was worth their time from a reimbursement standpoint to be seeing these patients in long-term follow-up, because they sometimes require more time on some, on a sort of unit basis. Anyway, the point is you do need to have a certain team of people to help with that, and a network of sleep medicine providers that both to refer in and also to help manage them long term. And that tends to be in the more sort of, metropolitan areas where you have that network of people. But it's not just Portland, as you can see, there are other places in the state that do have that can provide that as well. What was your other big picture question? I can't remember.
Oh, the location. Do you do these in like an outpatient surgical
yeah.
center, or is this the main OR?
Nope, these are in the outpatient surgery center. The sleep endoscopies obviously are super easy, quick outpatient. I mean, it's like a much shorter colonoscopy, but as this how I described to the families, to the patients, it's like a much shorter colonoscopy without the bowel prep. So they come in and go home. It only takes about 15 or 20 minutes to do that. And then the procedure itself to place the implant, like I said, is about maybe 90 minutes to 2 hours, and outpatient. And the vast majority of people go home the same, like without any issue. Recovery is not bad. So yeah, it's all done at outpatient surgery center here, at least. I imagine in most places that's how they have it set up.
I had a question then with age too, as someone ages, and then the battery needs to be changed in 7 years and another 7 years, or
right.
There's
So the battery replacement, I've only been doing them since 2018, I think. So I've done a couple of battery replacements, mainly people that were implanted elsewhere and then moved here. That's a really easy outpatient thing as well. You don't replace the leads. You basically just unplug the leads from the IPG and then just swap out the IPG and plug the leads back in. So that takes, I don't know, maybe 30 minutes. That's a pretty easy thing to do. In terms of age, so it's an interesting thing because there are studies that have shown, I don't know if they made it, they probably didn't make it into the review, but there are studies that show that older people actually do better with the, like 80-year-olds actually do better with this type of treatment than say 60-year-olds on average. And there's many reasons that, like in my mind, I think of it as like, if you have made it to 80, you're probably not massively obese. And the main cause for their sleep apnea, and this is just my sort of hand-waving explanation for that, is that maybe it's more of a muscle tone issue, right? Like things are just more lax in general. And this is more directly addressing that cause of their sleep apnea, as opposed to somebody who's maybe like 50 or 60, where there's a lot more obesity and stuff that is playing into that, and just sort of you're fighting gravity and so forth. And so, the patients that tend to do the best with this type of treatment, and this is in multiple studies have shown this, are skinny old women. Like the 75, 80-year-old women are the best patients for this treatment, or best responders on average.
Any other last minute questions? We've taken care of the Q&A in the outside of the meeting, but any other committee members, folks who have questions before we proceed to kind of take in a straw poll?
Oh, it's like answered.
Yeah.
Sorry, I didn't see these questions. Do we
okay.
have them answered?
You've gone through them. So
okay, all right. Okay.
So Jason, how do you want to proceed at this point?
That is really up to you, but somebody could make a motion, or you could just, do a straw poll to see how many, you could ask if anybody wants to change a recommendation. You could see how many people are interested in 2 options, however you want to proceed.
Okay. So we could take a straw poll, or to Jason's comment, there was a comment particularly about BMI or other kinds of things that are there any things in the recommended coverage you want to change? Or we have the ability to kind of say, we want to move this forward. We don't want to move this forward. We want to table this. We have several ways that we could proceed. It's not a binary process right now. So feedback from folks about kind of what's rattling around in your heads about what you would like to see for next steps, I think would be helpful from the committee members today.
And just to make it clear, the next step would be posting it for public comment
Right.
for 30 days, not
Thank you.
going directly to HERC. So you could, post it and get feedback before making a change on some of those issues.
It's a helpful clarification. Thank you.
And Linnea, so that's a good point. The question on the table, because currently this CPT code 64582 and 583 are not covered due to insufficient level of evidence. And so it's the question that if we keep the current algorithm, or that we change to this algorithm, or is it we change to this one but we modify this one?
Yeah, so Mark, you would have the option of saying, the evidence was not convincing for me, and I think that we should, have a different recommendation, like a recommendation for continued non-coverage would be one option. You could modify the staff recommendation. You could accept the staff recommendation as written. There's a variety of options.
I see.
That often makes it more complicated. That's not this binary yes or no or in or out. But that's we're really considering. If you think about our edict, is there enough evidence? I think that's actually a really good place to start the conversation, or to initiate this conversation right now, because that is the role that we have within the array of HERC work. And I think that goes back to, do we think that the presentation from the center gave us enough new evidence, potentially, is the way to think about it, compelling information that would change whether we think there is that statement that is not covered right now because there's not enough evidence.
Well, the other,
I see Mimi and Larry's hand up. I don't know who was first.
Larry was first.
Larry's first. Okay,
Yeah.
Go ahead, Larry.
yeah, thank you. I'll confess I have mixed feelings about this. And then the other consideration is the DICE procedure. If we go ahead, I mean, to my mind, there are several different options. One is table this. Another is to come back and then revisit it in 3 or 6 months and see if there's any new data. And then the other thing that complicates this is, if we approve this, then it makes sense to me that we would be obligated to approve the DICE procedure also.
That would be the decision of the HERC in terms of, we don't make the decision, we make a recommendation, but I just clarify that. But
Sure.
Mimi, you had some questions?
Yeah, actually not a question. I would just like to propose that that although there is some promising evidence, I feel that in terms of our usual level of criteria, that there's insufficient evidence to warrant moving this forward. So I actually would, my recommendation is to table this for a year, see if there's other additional evidence that it is that it will be an effective procedure in for treatment for our population in the Medicaid arena.
Are you making that recommendation, or are you making a motion?
I will make that as a motion.
Is there any second to that motion? To table this until a year from now? And I hear, Larry, you're saying you'd like to see more data. Are you willing to second Mimi's motion to table until for a year, and or till there is more significant evidence?
I would like to see more data, but I'm not sure I would want to wait a whole year.
Okay.
Linnea, I second that motion.
Okay, thank you, Mark. I won't put Larry on the spot. So there's a motion on the table to table the topic for a year, seeking more evidence. Can we take that to a vote? And the vote would go then in to the chat. Okay, do we have enough votes in, Jessica?
Still
No.
counting.
Yeah,
Okay.
we still need a few more.
I have just a quick question. Didn't we approve a procedure where Marcus's unit can come back to us sooner if they find more data?
That can always happen.
What
Mhm.
happens at that point, Larry, is we have regular meetings with the center. They would say to us in one of those meetings, there was XYZ trial was just published. It had phenomenal outcomes or horrible outcomes, and we think it really would change this.
And they are free to bring that forward at any time, is that right?
Correct.
Okay. All right, thanks.
We now have 6 votes.
And how many do we need?
6.
Okay.
Motion passes.
So is that everybody? Do you have anybody opposed or abstaining?
I did not see Larry vote. Oh, except he just did. So is that 7 now?
Yes.
So 7-0. Okay. So we will table this topic. That means we will not be having a December meeting because the purpose of that meeting would have been to discuss the public comments if this had been put out for public comment. So the next meeting would be in February, and the topic planned for that discussion is on the surgical interventions for sleep apnea. So that's the other half of the scope statement that Herc looked at in May, but they decided to split it into 2 topics because it was just too much evidence to review in a single report.
Thank you. Appreciate that. Anything else that we need to discuss or announce or anything before we close the meeting?
Just to say that the plan is for that to be a hybrid meeting again, although if as happened this time, everybody wants to attend online, we'll just do it that way. We are flexible. We like seeing people in person, but we also understand that the freeway is what it is.
I appreciate everybody's attendance today and the really high level discussion and our experts today really offering us good information, and the center doing some excellent work again, and just appreciate everybody being here today. And I think on that note, we can adjourn.
Great. Thank you, everyone.
Thanks, everyone.
Thank you. Bye-bye.
Thank you. Thank you, everyone.
Bye-bye.